Yeah, you can start.
Good evening, all respected faculties and presenter. I, Dr. Shravani Sarkar, express my heartfelt gratitude to all the esteemed faculties who are present here. Our topic for today is anesthetic management in cirrhosis of liver, who is posted for incisional inguinal hernia. But before starting this session, let us all pray to Goddess Saraswati for her divine blessings.
Screen is not saying.
Play the sound only.
Share the screen with audio. Huh. Yeah.
After praying to Goddess Saraswati for her divine blessing, may I request our very respected Honorary Secretary, Dr. Sukhvinder Bajwa sir, to say a few words before starting this session.
Thank you, Shravani. I think today's class is a very important topic, which is hardly being given a recognition in the long cases. But invariably, when you get these type of cases in emergency, I think it become like it can be devastating because liver cirrhosis sometimes they present without any symptoms also. And when you are going to give anesthesia, administer anesthesia in these patients, I think the hepatic enzymes are all into a decapacitated state, and the drugs can cause havoc in that patient. It's a very difficult case to manage, and although we are reading it right from our MBBS career, but now it is about the anesthesia and all our drugs. 90% of drugs are metabolized and cleared by the liver. So this is a very important topic, and none better than Dr. Ranju Singh and Dr. Upma Bhatia with their very bright student, Dr. Navneet. They are going to present this case. And I think every audience, they should be asking good questions because this is a very important topic. And I will be listening to it I want to enjoy this class today. Thank you, Sravani. You carry on from here.
Okay, sir. Thank you, sir. Today, today, our the skin coordinators will be me myself, Dr. Shravani Sarkar. I am working as assistant professor in the Department of Anesthesiology, Article Medical College Hospital, Kolkata, and my co-coordinator is Dr. Padmaja Madam, and I would request her to introduce herself and also our esteemed faculties for today's session. Dr. Padmaja. Dr. Padmaja, ma'am.
Hello, madam.
Dr. Padmaja,
Hello.
ma'am, I request you to introduce yourself and our esteemed
Hello.
faculties.
Thank you, madam, for handing over to me. Hello. Good evening, sir. Good evening, madam. I'm Dr. Padmaja, working as a consultant anesthesiologist and critical care fellow at Warangal Hospitals. Today, I would like to introduce all the faculty members. It's my privilege to do this. So, I would like to introduce our first faculty member, Dr. Ranju Singh, madam. She is the Director Professor at Lady Harding Medical College and Associated Hospitals. Madam, administrative achievements include she established the Delhi chapter of Indian Anesthesiology and Pediatric Anesthesiology, and currently she is the president of it and the Delhi chapter. Madam is the ex-vice president of Delhi chapter of ISA, and her academic achievements includes Madam achieved Academic Excellence Award in Medical Sciences in 2023 by Delhi University, and Public Awareness Award for CTR by ISA in 2023. Madam has been awarded the Honorary Fellowship.
Oh, Dr. Padmaja, you're not audible.
Shravani, you continue with it.
Yes, sir. Her academic academic achievements a lot, but what can I say? Her there's very little to say basically. But madam, his areas of interest are basically pediatric anesthesia, obstetric anesthesia, and life support. And our next esteemed faculty is Dr. Upma Bhatia Batra, ma'am. She is presently working as professor in Lady Hardinge Medical College, and her area of interest is airway USG guided regional anesthesia. So may I request Dr. Ranju Singh, madam, to introduce us her student and start the session. Thank you, madam.
Can you please tell the rules also, Shravani? Just tell the
Yes,
rules for today.
yes. And there are certain rules which should be followed for all the audiences. That is, if all the audiences are requested to keep their respective videos off, and they will be muted for the whole duration of the talk. And however, they can, if they are having any queries, they can type it down in the chat box. Later, we can answer those queries. Now, it would be, I will hand over the stage to Dr. Ranju Singh, madam, for her session. Thank you, madam.
Thank you so much, Dr. Sarkar. My heartfelt thanks to ISA, particularly to Dr. Bajwa and Dr. Madhuri for giving us this opportunity of holding this PG class. As Dr. Bajwa has already introduced, it's an extremely difficult and commonly encountered topic. And we wish through the case presentation to highlight all the salient points which are relevant for the exam for the student. And we have our brilliant third-year postgraduate student, Dr. Navneet, from the Department of Anaesthesia at Lady Harding Medical College, to present the case. We will go through the history examination and then follow it up with the discussion. I encourage all the students to post their questions in the chat box, and we will see you at the end of the discussion. Thank you so much. I invite Dr. Navneet to please start the case presentation.
Thank you, ma'am.
Please share your screen. Right.
Good evening, all. My patient is Mrs. Hurbano, is a 63-year female patient, a resident of Delhi. By occupation, she is a homemaker. She presented to the surgical emergency of our hospital with the chief complaints of swelling over abdomen for the past 1 year, pain abdomen for the past 3 days, nausea and vomiting, abdominal distension, and inability to pass stool and flatus for the past 1 day.
Okay, wait, Navneet, can you go back to your first slide, please?
Yes, ma'am.
Okay, now, whenever you have this presenting complaint, usually your presenting complaint is something which brings the patient to the hospital.
Yes, ma'am.
Okay, that is what she's been having, a swelling for 1 year, but she didn't come to the hospital for that 1 year. No, she's come now with probably abdominal distension, nausea, vomiting so this should take priority. You should first write this as your presenting complaint and everything later after that. So for all the students listening in, whatever brings the patient to the hospital, that becomes the presenting complaint.
Yes,
Okay?
ma'am.
Yeah, please carry on.
Patient was apparently well 1 year ago when she initially observed an abdominal swelling through the vertical midline scar. The swelling had an insidious onset, and the swelling increased in size gradually over the past 1 year. This she initially observed only the swelling. She initially observed the swelling only on coughing, straining, standing, and it usually reduced on lying down. However, now she complains that the swelling is irreducible even on lying down.
Okay.
The swelling was associated with dull, intermittent aching pain for the past 8 months, and she developed severe pain since the past 3 days, which was associated with nausea, vomiting, and inability to pass stool and flatus since the past 1 day.
So this pain is localized to the swelling, or is it anywhere else? This pain you have talked about is at the site of the swelling?
Yes, ma'am. It's localized.
Is it a generalized pain in the abdomen?
No, ma'am.
Okay. So she has now pain with nausea and vomiting and inability to pass flatus and stool.
Yes, ma'am.
Okay. Along with an increasingly large swelling over the past couple of months.
Yes, ma'am.
Right. Okay.
Past history. The patient had 2 previous surgeries. She underwent cesarean section 35 years ago under regional anesthesia, and she underwent a total abdominal hysterectomy 13 years ago, in which she mentioned history of multiple blood transfusions.
Okay. Another thing, Navneet, you've written TAH. Did the patient tell you that have had an abdominal hysterectomy? Or
No,
you
ma'am.
just figured it out yourself?
I figured it out myself, ma'am. She
Okay,
she
so
complained
yeah, it is better
uterus
in
removal.
history to please use the terminology which the patient will use. The patient never comes and tells you I've had a TAH. So
Sure,
make
ma'am.
sure that whatever you say is in the patient's language. So you could have said that the patient has given a history of uterus removal.
Yes, ma'am.
Unless the patient is of course very educated, or you have a medical student as a patient who's giving you these specific medical terminologies. Okay, so dyspnea on exertion is not a history thing. Breathlessness on working or on exercise is the term to be used. Similarly, total abdominal hysterectomy nahi use karna. Okay, say that the patient has had a uterus removal under some form of regional anesthesia, whatever time she's had it. All right.
Yes, ma'am. Yes, ma'am.
Right.
She also had a history of hospital admission 5 years back with complaints of pain abdomen, anorexia, dark colored stools, and yellowish discoloration of the skin. During that course of admission, she was diagnosed with hepatitis C, which was managed symptomatically, and she was advised for further follow-up. She was also diagnosed with with diabetes mellitus in the same period, and she was put on therapy, started on tablet metformin 1 gram BD and tablet glimepiride 2 milligrams BD.
Again, has
However,
she told you these medications? Did she show it to you, or did she give you any information that she's taking? Because you've specifically mentioned the dose and the drug. Has the patient told you this?
yes, ma'am.
Okay.
However, she also complained that she's non-compliant with the medications.
Okay.
There was no history of any other comorbidities. There was no history of chronic constipation, urinary straining, chronic cough, pruritus, no blood in stools or vomitus or bleeding from any other site, no history of easy bruisability, delayed wound healing, breathing difficulty, decreased urine output, or altered any history of altered sensorium. Personal history.
Upma, we can't hear you. I think you said something. Wait, Dr. Upma, I think wants to ask something. Would you unmute yourself, Dr. Upma? We can't hear you. Upma, we still can't hear you. Would you,
Ma'am, it's okay. You continue.
yeah, so Upma, meanwhile, why don't you just log out and then re-log in if we can't hear you? Okay, so why all this detailed history, constipation, urinary staining, chronic cough? Why have you asked all this, Navneet?
Ma'am, the patient, all these symptoms indicate there's increased abdominal pressure, which might have precipitated the hernia. So we just
Okay,
wanted to
okay,
rule it out.
okay, okay. And all
And
this decreased output, altered sensorium, how does this gel in with the rest of your history?
ma'am, she also gave the history of being diagnosed with hepatitis C.
Okay.
So keeping that in mind, we also wanted to take the history regarding the complications of hepatitis.
Okay, okay, okay. So since this is a known case of hepatitis, she's already told you that she suffers from a disease related to the liver. So your history taking becomes a little simpler. You're trying to rule out other, I think, extrahepatic manifestations
Yes,
probably
ma'am.
of liver disease. And also, there is no history related to the diabetes in this, what I can see, Navneet? Once
No,
you
ma'am.
already know that she's diabetic also, all that we teach you about diabetes, we'll not go into this at this time, but all that autonomic disturbances which we talk about with diabetes, although it's only 5 years, but we don't know how long she's had it, should also be part of your history. So that
Yes,
feeling of fullness, everything related to autonomic dysfunction, which we tell you, should also be a part of your history, besides this incisional hernia from what I can figure out and your chronic liver disease. Okay?
okay, ma'am.
Okay,
Yes,
chalo
ma'am.
aage.
Personal history. Patient consumes a mixed diet, uh, but she complains of decreased appetite and disturbed sleep. She also complains of constipation on and off for the past 1 year. There was no history of any addiction, any drug allergies, and no tattoos were present all over the body. There was also no history of any intake of herbal medication and no recent travel history.
Okay, so why sleep? Wait. Why sleep?
Ma'am, might be there might be a component of encephalopathy, which is
Okay, okay. Which
hampering her
you
sleep.
think will manifest as delayed, as disturbed sleep. Okay.
Yes,
And
ma'am.
all this addiction, herbal medication intake, all this drug allergy.
Ma'am, these can also be the etiological factors of hepatitis. So we would
Okay.
like to rule out any other causes which can lead to her.
So from this history, it's very clear from, since the patient's already told you that she has some form of chronic liver disease.
Yes, ma'am.
Right? So what do you think can be the common causes of liver disease? That will help you narrow down your history. All
Yes,
this
ma'am.
past history which you are taking should be help reach a diagnosis, a differential diagnosis. For that,
Yes,
you
ma'am.
must know the common causes of chronic liver disease.
Yes, ma'am.
Can you enumerate them, Navneet?
Yes, ma'am. The common causes can be, first of all, viral
Okay.
diseases like hepatitis B virus and hepatitis C virus.
Okay. Any
Can lead
form
to,
of viral hepatitis, chronic
yes,
viral
ma'am.
hepatitis. Very good.
It can be alcohol-induced hepatitis.
Very good.
It can be non-alcoholic steatohepatitis.
NASH, right?
Yes. And we can also have autoimmune hepatitis,
Right.
biliary disorders like primary biliary cholangitis and primary sclerosing cholangitis,
Okay.
metabolic disorders like Wilson's disease and hemochromatosis,
Okay.
vascular causes like Budd-Chiari syndrome,
Okay.
and even other drugs and toxins.
Okay. Okay. So even if you can't remember all these complicated names for all the students, just broad categories of autoimmune hepatitis, acute viral hepatitis, non-alcoholic fatty liver disease or non-alcoholic steatohepatitis, that is NASH, cholestatic diseases. If you just remember the broad outlines, you will be able to get across this question and then the examiner can move on to the next question. So this basically, once you know the causative feature, the causes of chronic hepatitis, you can exclude them all one by one in your history. So because drugs and toxins is an important cause, therefore I think this addiction, drug allergy, herbal medication history is there. And family history methodology I think will follow. This will help you reach a diagnosis of why the patient has a chronic hepatitis, chronic liver disease, if this history of hepatitis C was not so specific. Okay,
Yes,
carry
ma'am.
on, Navneet.
Family history was not significant.
Okay.
Obstetric history. Patient was para 3, live 3, and no abortions. The first two children were delivered via normal vaginal delivery, and the third child was born via cesarean section.
Okay.
And menopause was attained at 40 years of age.
Oh, fine.
General physical examination. The patient was conscious and oriented to time, place, and person. She had a heavy belt with weighing approximately about 78 kgs with a height of 164 centimeters, which sums up to a BMI of 29 kilogram per meter square. Pallor was present, icterus was present, cyanosis and clubbing were absent. Pedal edema was present, which was pitting in nature.
Okay.
Lymphadenopathy was absent. Alopecia, flapping tremors, spider navy, palmar erythema, and fetal hepaticus were absent, and the JVP was not raised.
Okay, so you have taken into account all the extrahepatic manifestations of a chronic liver disease and looked for them on your general physical examination.
Yes,
fine.
ma'am. Vitals. The pulse rate, patient's pulse rate was 104 beats per minute. It was measured in the right radial artery. It was regular, bounding in character. The arterial wall
Why
was not
should the patient have a bounding pulse?
Ma'am, these patients might have an hyperdynamic circulation.
Okay.
So
Okay.
there will be increased cardiac output,
Right.
which will lead to might show us the bounding pulse.
Right. Carry on.
Arterial wall was not palpable, and there was no radial or radiofemoral delay.
Okay.
Blood pressure was 114 by 64 millimeters of mercury. It was measured along the right brachial artery in supine position.
The diastolic appears to be slightly on the lower side as compared to the systolic.
Yes, ma'am. These patients will have a diastolic dysfunction, and the pulse pressure will be increased as
They will stay vasodilated and the pulse pressure
yes,
will be
ma'am.
wider. Okay, so she's likely to have a lower diastolic pressure. Okay, carry on.
The respiratory rate was 20 per minute, and saturation was 98% on room air.
How did you measure the saturation on room air at the time of examination? Was there a monitor available?
No, ma'am, but we carry an portable pulse oximeter along with us.
Okay. So like you carry your hammer, you have a portable device with you.
Yes, ma'am.
Okay. So in case you don't have it, please do not mention this on examination if you're not measured it. Any feature in this which you have not actually measured should not be mentioned in the examination. All right? Okay, carry on.
The airway examination.
Is there anything significant?
No, ma'am, no significant.
Okay. Another thing, I can see that you've mentioned the thyromental distance as 3 finger breadths.
Yes, ma'am.
Please, this is for all the students who are listening in. The mouth opening and the measurement of all these distances should not be in finger breadth. Okay. The commonest question you were told that the examiner is going to ask you whether finger breadths of your own or the patient's, but this is no longer relevant because even if it is the patient's hand, an obese patient will have 3 finger breadths equal to 6 centimeters and a very thin patient will have 3 finger breadths equal to 4 centimeters. So please measure all these distances in centimeters. Do not mention finger breadths. Mouth opening, so many centimeters. Thyromental distance, so many centimeters. Okay? Please move on. If this is not significant, go ahead.
Systemic examination.
Okay.
Abdominal examination. On inspection, the abdomen was distended.
Can we run through it a little faster, Navneet?
Yes, ma'am. There were prominent veins all over the abdomen. The swelling was present below the umbilicus, overlying the vertical scar extending from the umbilicus to the pubic symphysis. It was approximately of 12 into 15 centimeter in size, ovoid in shape, and there were no skin color changes over the swelling. The cuff impulse was present, and the swelling size increased on performing the straight leg raise test. And there was no visible peristalsis over the swelling. And the flanks were full.
Okay, so it's obviously a incisional hernia. It's a hernia which is reducible, and then it's through the scar, so it's obviously an incisional hernia. Okay, carry on.
On palpation, tenderness was present. There was no guarding or rigidity. It was a single large swelling of size 12 into 15 centimeter, irreducible in nature. It had a smooth surface and margins were not well defined.
Okay.
The abdominal girth was measured to be 96 centimeters.
Okay.
Fluid thrill was present and the spleen was not palpable.
Okay. You were able to feel the fluid thrill?
Yes, ma'am.
Okay. Carry on.
On percussion, shifting dullness was present and liver dullness was noted in the fifth intercostal space over the midclavicular line.
Right.
And on auscultation, bowel sounds were absent and no venous hum or arterial bruit was heard.
Okay. Anything significant in the CNS?
No, ma'am.
Okay, carry on.
Respiratory system and
No. If there's nothing significant, please move on.
No.
So you have a provisional diagnosis now based on this history and examination.
Yes, ma'am.
Yes.
My provisional diagnosis is the patient is a 63-year-old female with a known case of hepatitis C and diabetes mellitus with ascites, presented with abdominal swelling associated with severe pain, nausea, vomiting, and inability to pass stool and flatus, which is suggestive of an obstructed incisional hernia.
So this is your summary, please. Remember, the severe pain, nausea, vomiting is part of your summary. If the examiner asks you provisional diagnosis, then she is a 63-year-old female, a follow-up case of hepatitis C with diabetes mellitus, with ascites, and an obstructed incisional hernia. The rest is all summary. It's not part of your provisional diagnosis. Okay. Now, obviously, since this patient has a chronic liver disease, what do you think this could be? The hepatitis C information which is given you, what could it have led to in so many years, maybe what, 10 odd years?
It could have led to, ma'am, liver cirrhosis.
Okay, what is cirrhosis?
Yes, ma'am, am I audible now?
Yes, now please carry on, Upma.
Yeah, I just wanted to ask, don't straight away jump to cirrhosis, because still you didn't get anything in your examination findings that could corroborate with the cirrhosis, without investigation.
Cirrhosis is a diagnosis on biopsy.
Yeah.
Yes, ma'am.
So you can just say patient is now having a chronic liver disease with ascites. So I would like to investigate the patient further to point out towards some definitive diagnosis. Okay?
Yes, ma'am.
And since she is having a history of hepatitis C, she might be a case of liver cirrhosis, which I will confirm with my investigations.
Ma'am.
Okay, what is cirrhosis, but?
Yeah.
Cirrhosis is cirrhosis is an end-stage liver disease, which is characterized by chronic inflammation, in which there is disruption of the lobular architecture of the liver, and there is constant regeneration of these parenchymal nodules, which eventually lead to fibrosis.
Okay, so there's a lot of parenchymal scarring and there's a nodular structure with a lot of fibrosis.
Yes,
and the entire structure of the liver gets disrupted, right?
Yes, ma'am.
Now, because of this cirrhosis, which body systems do you think get affected? That is, if the examiner asks you, what are the extrahepatic manifestations of chronic liver disease? It's the same thing, either systemic manifestations, extrahepatic manifestations, involvement of systems, and pathophysiology, all will focus on the same thing, talking about extrahepatic manifestations of chronic liver disease. So you should be able to enumerate this system-wise.
Yes, ma'am.
Okay.
So
can we start with the systems most important to us?
Yes.
Maybe, Navneet, which system?
Yes, ma'am. Cardiovascular system, ma'am.
Cardiovascular system. Tell me.
Yes, ma'am. These patients usually have an hyperdynamic circulation with a high cardiac output, and they also have a low systemic vascular resistance, which will lead to systemic and splanchnic vasodilation and cause hypovolemia.
Okay, so that means these patients have a hyperdynamic circulation. In spite of that, they have relative hypovolemia. Okay,
yes, ma'am.
Because all that large amount of blood is pooled into the splanchnic circulation. So
yes,
the
ma'am.
Systemic blood pressure is a little low.
Yes, ma'am.
Okay, and they have a hyperdynamic circulation. Then what happens as a result of this arterial hypotension and systemic vasodilatation?
Ma'am, preload is decreased. So hence the cardiac output eventually increases,
Okay.
and this might lead to further condition known as cirrhotic cardiomyopathy over the time.
Okay, so there's an increase in heart rate and stroke volume. There's an increase in cardiac output and a decrease in systemic vascular resistance. Simultaneously, this arterial hypotension will stimulate neurohormonal responses, which will lead to the stimulation of the renin-angiotensin-aldosterone system,
Yes, ma'am.
will lead to water retention and renal vasoconstriction. Okay,
Yes.
so high cardiac output, low systemic vascular resistance, tachycardia, hypotension, and then, as you said, cardiomyopathy, which means that both systolic and diastolic function will be decreased. Is there any rhythm abnormality or electrophysiological abnormality also?
Yes, ma'am. There will be rhythm abnormalities. The QT wave can be prolonged on ECG.
Okay. There is chronotropic incompetence and there can be QT interval prolongation in these symptoms. And you should be able to look at all these conditions while you're examining and then finally investigating the patient. What about the respiratory system?
In the respiratory system, ma'am, there's basically mechanical compression of the lung due to the increased size of the liver, and also maybe due to ascites. So due to this compression, there is the functional residual capacity is decreased, which will lead to lead to alveolar hypoventilation. And these patients may also be more prone to atelectasis.
Okay.
And
which becomes worse in the supine position and even further worse with induction of anesthesia. Okay.
Yes,
so for all the students listening in at this point of time, your Viva can divert towards FRC and its related consequences. What is the normal FRC? How is it reduced under anesthesia? How it is reduced with change in position? What is the relationship of FRC and the closing capacity? Everything related to FRC can be asked at this point. Okay. We will not divulge into that point at this time, but FRC is reduced in these patients. There is arteriovenous shunting, there is alveolar hypoventilation, there is VQ mismatch. Along with that, what else?
Then, ma'am, we can also have pleural effusion.
Very good.
And when it's increased in quantity, it is also known as hepatic hydrothorax. Because
so
increased
because of the there is a flow of all this ascitic fluid passively into the pleural cavity, which can then cause hydrothorax also. Right. And then one more important thing which the examiner would want to hear from you at this point of time is the occurrence of
hepatopulmonary syndrome, ma'am.
And then they will ask you, what do you mean by hepatopulmonary syndrome? You should be able to explain it. What is the triad which constitutes the hepatopulmonary syndrome?
Yes, ma'am. The triad is in presence of a liver disease.
In presence of chronic liver disease.
Chronic liver disease. And there is hypoxemia. And the presence of intrapulmonary vascular dilatations.
Okay. So the presence of chronic hypoxemia, you should be able to explain. The PaO2 less than 80 millimeters of mercury while breathing room air in any position. Okay. Along with intrapulmonary vascular dilatation. So AaDO2 is increased. The alveolar arterial shunt is increased. There is hypoxemia while breathing room air to less than PaO2 80 millimeters of mercury in any position, together with presence of pulmonary hypertension. Okay, that is the exact definition. And what are all the effects leading to? As an anesthesiologist, why should you be worried that patient has all these far-reaching respiratory effects due to the liver disease? How does it make a difference to you?
Perioperatively, a patient might encounter hypoxemia. So we must know the different causes to rule out what
before that, all these patients are the ones who will require definitely pre-oxygenation.
Yes, ma'am.
Secondly, these are the patients who will have rapid desaturation with onset of apnea.
Yes, ma'am.
And these are the patients, because of many reasons, who can develop intraoperative hypoxemia.
Yes.
And lastly, because of these changes, they may need higher care in the postoperative period, which means they may require HDU admissions, they require more intensive monitoring and oxygen therapy in the postoperative period also. So right from preoperative to postoperative, all these respiratory changes have a lot of anesthetic significance, which you should be able to enumerate.
Yes, ma'am.
Okay. Okay. What are the other systems?
Ma'am, gastrointestinal system.
Okay.
Okay.
In the gastrointestinal system, ma'am, we'll have a portal hypertension.
Okay.
It is basically due to increased there's fibrosis in the sinusoids, which will increase the resistance to the hepatic blood flow, which
Portal
eventually
venous blood flow, basically.
yes, ma'am. Portal venous blood flow, which will intact these portal pressures will increase, and it will be transmitted to the splenic vein, which will eventually lead to splenomegaly, which is the first sign of portal hypertension. And yeah.
See, basically what happens due to the disturbed architecture of the liver due to chronic fibrosis, the impedance to portal venous blood flow through the liver sinusoids is resistance is increased. So there is development of portal hypertension, and the portal vein, it is formed by the combination of which two veins, superior mesenteric vein and splenic vein.
Yes.
So the resistance and pressure in these veins is backflown towards the splenic vein, and there is development of portosystemic shunts to relieve these pressures. Okay, if I ask you now, what is the normal portal venous pressure gradient?
It is 3 to 5 millimeters of mercury, ma'am.
Yeah, and more than 5, you will classify it as a portal hypertension. And how can you classify the severity of portal hypertension?
Severity of portal hypertension, ma'am. It is graded according to the pressures, ma'am.
Okay.
And 5 to 8 is grade 1.
Yes.
8 to 10 is grade 2, and 10 to 12 is grade 3. And more than 10 to 12 pressure, it can lead to variceal bleeding and other complications.
So that is the significance of knowing the portal venous pressure and its values. Okay,
yes.
So shall we come to the investigation to how
at
to
this
detect?
time also, Upa, the student can anytime be asked at this time when you're talking about the portal blood flow, you can be asked about the normal blood flow of the liver.
What is the normal
yes, so the dual blood supply of the liver is extremely important, and you should be able to explain the component of hepatic arterial flow as well as the portal venous flow. Navneet, can you tell us? You also have a beautiful slide to show.
Yes, ma'am.
Good.
The liver has a special characteristic feature, which is known as the dual blood supply, in which the blood supply is mainly by the portal vein, which is up to 75% of the blood volume, and the hepatic artery, it supplies about 25 to 30% of the entire blood volume it requires.
Okay.
And but the oxygen concentration is less with the portal vein.
Okay, so this is a theoretical question for all the students. You should be able to reply to this answer, and you should also be able to tell us that what is the hepatic arterial buffer response. Okay, hepatic arterial buffer response can also be an important short note in your exam. So you should be able to explain all this with the help of a diagram if the examiner asks you, and explain the importance of this dual blood supply. Okay, there are a lot of other systems involved. We will just take briefly 2 systems. The gastrointestinal system is involved, the renal system, metabolites, electrolytes, CNS, and coagulation. All these systems are involved. So out of these, besides the cardiovascular and the respiratory, the important system that is involved is the coagulation system. Navneet, can you explain what is the effect of liver disease on the coagulation system?
Ma'am, in the coagulation system, all our coagulants, procoagulants and anticoagulants are produced in the liver, except for factor 3, that is tissue thromboelastin, calcium, factor 4, and the factor 8, that is the von Willebrand factor. So the production of all these are decreased.
Okay.
So traditionally, it was assumed that we should get an INR done, and
Okay.
based on its value, correction was
So
given.
now that is an old concept.
Yes, ma'am.
Remember that initially we used to just talk about INR. Now there are procoagulants as well as anticoagulants, which are both changed. So there is what is known as a rebalance. So in any particular patient, depending upon what is increased and how much, and what is decreased and how much, the ultimate balance is reached.
Yes,
So
ma'am.
procoagulant factors like the von Willebrand factors is increased, whereas there is decreased plasminogen, there is decreased protein C and S. And on the other hand, the anticoagulant factors, there is decreased thrombopoietin synthesis, there is dysfibrinogenemia. All these lead to a decrease in the anticoagulant. So the combination of this, or the dynamic balance of these, actually decides what is wrong with the patient. So merely an INR raise is not going to tell you that there is a coagulation dysfunction. You
Yes, ma'am.
need dynamic tests for coagulation, such as TEG,
Yes,
ROTEM,
ma'am.
to evaluate the coagulation system and then manage the dysfunction in the coagulation system. So if you have the ability and I should say you have this availability of TEG in your institute or ROTEM, you should do that along with your platelet count and your INR to actually decide what is wrong with the patient. Okay,
Yes,
so
ma'am.
there can be anemia, there can be thrombocytopenia, there can be hyperfibrogenemia, there can be a lot of things, but the ultimate balance will be very dynamic in any patient. Okay, so
Yes, ma'am.
briefly, do these patients have a vitamin vitamin K deficiency, Navneet? And can you correct this with vitamin K, the deficiencies?
Ma'am, these patients might have a vitamin K deficiency, but it is not corrected in a hepatocellular disease,
Okay,
ma'am.
so usually it's not a deficiency of vitamin K in hepatocellular disease, unlike an obstructed patient where vitamin K deficiency occurs. But these patients have a lot of nutritional component. They have
Yes, ma'am.
anorexia, they have decreased intake, they have increased catabolism, they have hypoproteinemia, and they have decreased absorption of fat-soluble vitamins and vitamin K. So there may be a component of deficiency of vitamin K as a result of the nutritional deficiencies.
Yes, ma'am.
Okay. And lastly, very briefly about the CNS, because it's so relevant to our investigations and examination. What is the effect of the liver disease on the CNS?
Ma'am, in the CNS, we maybe have patients going to hepatic encephalopathy
Okay.
due to it is mainly due to the accumulation of ammonia. The liver as a function of detoxifying ammonia is being lost.
Okay.
And the ammonia is also metabolized in the brain and the skeletal tissue. The liver is the primary site for ammonia metabolism, which which is done via the urea cycle. But this cycle, this function cannot be done by the brain and the skeletal muscle cells.
Okay.
So when the concentration of ammonia increases, the brain cells, that is basically the astrocytes, they have a glutamate synthetase, which the ammonia is converted into glutamine with the help of glutamate synthetase.
Okay.
And this increase in glutamine gradually increases intracellularly. It is an osmotically active component. So
Yes.
it pulls water into the cell, and which results in astrocyte swelling and cerebral edema.
Yes.
Okay.
So
yes, Upma.
So basically what happens is there is failure of conversion of ammonia into urea, and this
Yes, ma'am.
ammonia then crosses the blood-brain barrier and gets accumulated into the cerebral cells.
Yes,
And
ma'am.
also because of the portosystemic shunting, the gut toxins which were initially shunted away to the liver, now they get distributed to the systemic circulation.
Yes,
And now
ma'am.
they also increase the level of inhibitory neurotransmitters into the brain. So that is the
Yes.
reason for development of hepatic encephalopathy. So
Yes.
any factors that you can tell which can predispose and increase the incidence of hepatic encephalopathy?
Yes, ma'am. There might be several precipitating factors like constipation, dehydration. There might be excessive intake of dietary protein. There
Yes.
might be a history of upper GI bleeds.
Yes.
and there might be a bowel obstruction, sepsis, and infections, and spontaneous bacterial peritonitis. There can be uremia, azotemia, hypoxia itself can be a cause. Hyperkalemia and hypokalemia too can precipitate.
Yes. And even hyponatremia also can precipitate hepatic encephalopathy.
Yes,
So many
And
of these are under
rapid
your
tapping.
control. It's important to highlight those features. Why we are talking about hepatic encephalopathy in so much detail is there are many factors under your control which can precipitate hepatic encephalopathy. So those should be taken care of.
And one characteristic feature of this hepatic encephalopathy is that it is waxing and waning. And there is a grading of hepatic encephalopathy that is being given. That is the WES grading. All of the students, they can have a look and they can read about it. Hai na?
yes, ma'am.
About the hepatic encephalopathy.
So hepatic
And,
encephalopathy, yeah, please.
Hepatic encephalopathy, presence of hepatic encephalopathy means that the patient is having a decompensated liver disease.
Yes.
Any of the complications like variceal bleed, jaundice, ascites, or hepatorenal syndrome or hepatopulmonary syndrome, this will point towards a decompensated cirrhosis. It is important because of risk stratification. The mortality of decompensated cirrhosis is very high as compared to the compensated cirrhosis. The compensated cirrhosis mean survival is around 12 years. Whereas for decompensated cirrhosis, it is reduced to 2 years only. Okay. So these are important for risk stratification for your patients.
Okay. So one, for risk stratification. Secondly, it will influence your course of anesthesia.
Yes.
You must know the preoperative status of the patient in terms of CNS awareness. And so that if there is a problem post-operatively, you can corroborate the two. And all these factors, as I've said, are in your hands, and you should control them well so that you do not precipitate hepatic encephalopathy during the course of anesthesia. Okay. Now, there are a lot of other systems involved. If we run into all the systems, we will run short of time. But for the students listening in, nutritional, renal is of course important. So let me just highlight that these patients can develop acute kidney injury, and that can be precipitated. That can be pre-renal, renal, or post-renal. Pre-renal can be because of the hypovolemia. Then you can have renal parenchymal disorders, and you can have hepatorenal syndrome. And in fact, 70% of the cirrhotic patients will have some renal dysfunction without any definitive structural change. Then the examiner can ask you, what is hepatorenal syndrome? What is the clinical significance? How you manage? All this is quite a lot of theory, and you must know hepatorenal syndrome. It can also be a short nose. Okay.
Yeah,
Remember, it's a functional defect, and the only treatment for hepatorenal syndrome, besides managing the hypoperfusion, treatment with vasopressin analogs, can be done, but it's a functional defect in the kidney. Then you have metabolite and electrolyte disturbances, like you can have hyponatremia, you have hypoalbuminemia, you can have hypoglycemia. All these should be elucidated well in your answer. Your examiner can ask you any of these systems in detail, including the elimination of sepsis and all the details of nutritional deficiencies. Okay. Now, if this patient comes to you, you have this patient, she's obviously here for an incisional hernia surgery. Now, if you see this patient in the pre-op, can you just summarize what are your preoperative concerns now for anesthesia?
Yes,
The
ma'am.
examiner cannot go into the details of systemic examination or history and can directly ask you, what are your anesthetic concerns? Can you just outline them for us, Navneet?
Ma'am, anesthetic concerns, we have to basically, we would like to correct our fluid and electrolyte imbalances.
Okay, so anesthesia concerns are the presence of fluid and electrolyte imbalance.
Yes, ma'am. And we can check the nutritional status of the patient.
The presence of nutritional deficiencies and their correction.
Yes, ma'am. Coagulopathy and its corrections, ma'am.
The presence of coagulopathy and its correction.
And as we discuss, different system might be involved, like the pulmonary systems and the cardiac system. So any
optimization of whatever is possible in the cardiovascular and respiratory system, and control of ascites.
Ascites.
In your patient, ascites was present, so you should know how to take care of and control ascites. Was it controllable?
Yes, ma'am.
So then examiner can also ask you, how do you manage ascites? What is the therapy that is used, medical as well as surgical? What is large paracentesis now that ascites has just come up? What do you mean by large paracentesis? That is removal of the ascitic fluid.
When there is removal of more than 4 to 5 liters of ascitic fluid,
In some
it is termed
places
as
it's 4, some places it's 5 liters of ascitic fluid in a single sitting. In a
it is
single
a
sitting.
sitting.
Okay.
Yes, ma'am.
Does it have any relevance to the anesthesiologist?
Yes, ma'am. There'll be we must take into consideration the fluid replacement should be done adequately. It is, and plus in such large there will be we might have to replace it with albumin.
Okay, you should. So when you have a large paracentesis, more than 5 liters, you must replace albumin simultaneously. So 6 to 8 grams per liter of albumin for every liter of fluid after 5 liters that is extracted.
Yes.
Okay, so the perioperative concerns again are optimization of the nutritional status, correction of fluid and electrolyte imbalances like hyponatremia, control of ascites, excluding pre-existing infection, correction of coagulopathy, avoiding nephrotoxic and hepatotoxic drugs, and optimization of all these organ systems that are present. What are the factors which adversely affect the outcome in any patient with chronic liver disease undergoing non-hepatic surgery?
Presence of infection.
Okay. First of all, the stage of cirrhosis.
Yes, ma'am.
If it's an early onset disease, it doesn't really make a difference versus the advanced disease. So stage of cirrhosis. Okay.
Stage of cirrhosis.
What else?
The type of surgery which is indicated.
That means whether it's an emergency surgery or elective. So anytime the patient undergoes emergency surgery, the outcome is worse.
Yes,
okay. What else?
And it will depend on the stage of
presence of associated complications, whether it is a compensated or decompensated cirrhosis. And is there any grading systems which have been done to quantify the surgical risk?
Yes,
ma'am. There are specific gradings.
Yes, ma'am. Most
we'll
commonly
talk about risk assessment. We'll talk about old age, the type of surgery, whether it's an open or laparoscopic surgery, emergency or elective surgery, stage of cirrhosis, and the presence of comorbidities. These are 5 important things which influence the outcome.
Yes, ma'am.
Okay. Now, as Dr. Upma has mentioned, when you talk about the stratification for risk, how do you stratify the risk preoperatively for these patients?
Ma'am, risk stratification is commonly done using 2 scores. The first one is the Child-Turcotte-Pugh score. This is calculated using the patient's serum bilirubin and albumin concentrations, INR, and the severity of encephalopathy and ascites is assessed.
Very good. Okay. And it's divided into 3 classes, A, B, and C.
Yes, ma'am.
Okay. Is there any problem with this very commonly used score? I know it's very good and we use it very commonly. Is there any problem with this CTP score?
Yes, ma'am. It is actually it is very subjective because the grading of encephalopathy and ascites is dependent on the observer, and it might change with different observers.
It is very subjective, particularly the examination for ascites and encephalopathy in these mild to moderate grades is very subjective. So that is not a good thing in any score. What else?
And also, ma'am, the cutoff values are arbitrary, subjective in nature.
Okay. So whoever made this score, these were very arbitrarily put off. This bilirubin cutoff of 3, albumin cutoff of less than 2.8. These are very arbitrary values, which makes the score less effective. And moreover, there is a ceiling effect. For example, any patient who has a bilirubin of 3 is also in the same class and has a bilirubin of 15 is also in the same class.
Yes, ma'am.
So there is a ceiling effect. It's got an arbitrary cutoff value, and there is a lot of subjective variability in the evaluation of parameters. Okay.
Yes, ma'am.
So an important, this score was improved upon, and you had another score now.
Yes, ma'am. We had the MELD score, which is the model for end-stage liver disease. It was calculated using 3 three parameters. That
Okay.
was the total bilirubin, the INR ratio, and the serum creatinine.
Okay, so obviously it's more objective because it's based on certain parameters, and all the
Yes, ma'am.
subjective part which was there in the CTP score have been removed.
Yes, ma'am.
A further modification of MELD score also took place. Do you know that?
Yes, ma'am. It was no. They also took in the consideration of the sodium concentration,
Yes.
So that's
and it
known
was
as the UK model of end-stage liver disease, UK
yes,
MELD.
ma'am.
Okay. In
Yes,
that, there is involving the serum sodium levels also. So hyponatremia was taken into course.
yes, ma'am.
Any other, just for the sake of the names, any other scoring system have you heard of besides these CTP and MELD score?
Yes, ma'am. There is the vocal pen model,
Okay.
and also the
So that's a
Mayo
D-Viva
Clinic.
question. That's a
Yes, ma'am.
D-Viva question. If they reach till here, there are two more scores. One, as you very nicely said, is the vocal pen model, which the students can read. Anything else?
And the Mayo Clinic post-operative risk,
Okay.
mortality risk in patients with
Cirrhosis
cirrhosis type beta.
calculator. Very good. So
Yeah.
these are scores which are not essential for you to know. If you know them, you get more marks. But if you don't know them, no marks are cut.
Ma'am,
Okay.
here I would like to
Yes.
add one thing that MELD score was initially formulated to grade the severity of the patient for liver transplant. But
Right.
nowadays, it is being used for risk stratification also, and it has been observed that the CTP scoring provides a good risk stratification for short-term outcomes, whereas MELD score provides good risk stratification based on the long-term outcomes. And MELD sodium provides a middle outcome for at least for the 90 days after the surgery.
Right.
Basically, these are the scores that are meant for the surgical patients. The risk stratification based on their clinical condition, what will be the risk of the surgery. And there is a correlation between the MELD score and the CTP score.
Right.
If the MELD score is less than 10, it will correspond to child's grade A. 10 to 14 will be child's grade B, and more than 14 will be child's grade C.
Child C.
So that way you can corroborate both these scores. Okay.
Okay. Now we've done the risk stratification. We've done a history and examination. Now the patient is with you for surgery. How will you prepare this patient? What investigations will you do? And what optimization will you like to have in this patient? She's for an incisional hernia repair, which seems to be obstructed. So you don't have much time.
Yeah. And keep your investigations focused with respect to this patient only. Okay.
Yes, ma'am.
Investigations and optimizations.
Okay.
I would like to get a complete blood count, ma'am, and blood grouping and matching done. Liver function test,
Okay.
a kidney function test,
Right.
prothrombin time and internalized numerized ratio, serum electrolytes.
Okay.
As she's a diabetic, I would also like to get the fasting blood sugar and postprandial blood sugar with HbA1c.
Even if
Chest
she is not a
X-ray.
diabetic, then also being a chronic liver disease, you have to get the blood sugar value.
You should get the blood sugar done for
Yes,
any
ma'am.
chronic liver disease patient. Okay.
And I would like also get a chest X-ray done.
What
to
will
rule
the
out.
X-ray tell you?
We might look for any possibility of effusions.
Okay.
If
We have talked about that she may have a hydrothorax, she may have an effusion,
Yes,
she
ma'am.
may have some pre-existing pulmonary disease. So you
Or
must
some
get
respiratory infection might be there.
respiratory infection. You must get an X-ray done. What about the ECG?
on ECG, any rhythm abnormalities
Okay.
can be seen.
Particularly,
And
you mentioned something when we were
yes, ma'am, prolonged QT.
QTC. So
Yes,
QTC
cirrhotic
must be
cardiomyopathy.
seen, rhythm abnormalities must be seen. If there is evidence of cardiomyopathy, then you may have other manifestations seen on the ECG. You must look out for all of them. Okay. Then,
And I would like to also get an EVG done on
Okay.
room air so
Okay.
that we know what's her
what's her baseline
P-
level? Absolutely.
baseline level of VO2. Yes,
Okay.
ma'am.
Particularly, her oxygenation should be known preoperatively to you.
Yes, ma'am.
And
Right.
you can also get alveolar arterial gradient to classify
ADO2
whether
is
the patient
also
is having
important to-
hepatopulmonary or pulmonary artery hypertension or anything like that. Okay?
Absolutely.
And I would also like to get a 2D echocardiogram done, ma'am,
Yes.
Okay.
to rule out any diastolic dysfunctions.
Yes.
It will
Diastolic
also
dysfunction is known in cases of cirrhotic cardiomyopathy.
Yes, ma'am.
So
And
yes, she may have systolic dysfunction, diastolic dysfunction,
ma'am.
cardiomyopathy. She already has a hyperdynamic circulation. Everything for all these patients, whether they are diabetic or not diabetic, and 2D echo must be done preoperatively.
Yes.
Okay, right.
And then ultrasonography of the abdomen
Okay,
to know the exact contents of the hernia. Also,
okay,
to quantify the volume of ascites if possible,
okay,
and it will also tell us if any other organomegaly is present.
okay.
Yes. And it will guide you about the nodular architecture. It will give you some diagnostic insight. Till now, you were not knowing whether it is a chronic liver disease or cirrhosis.
Yes,
So you
ma'am.
will get an idea about the liver architecture.
Yes, ma'am.
Increased nodularity, left lobe hypertrophy, okay, and disturbed
Yes.
echo texture of the liver. These
Right.
will point towards the development of cirrhosis. And another thing is nowadays you can do a fibroscan,
Right.
Yes, ma'am.
which is a measure of liver stiffness on ultrasonography along with other factors.
Yes.
Okay? So you can
Yes.
do
Yes.
that, and you have certain quantitative values for the fibroscan and liver stiffness, which can help you in grading portal hypertension further.
Yes.
Yes, ma'am.
Yes. Yes. And then, as you've said, TEG is an important thing to do. If you
Yes.
have the facility, you must get the TEG done. So in
Yes,
this, you don't have a platelet count. I can't see a platelet count anywhere.
CBC
Yes,
here.
ma'am.
So CBC, you must mention a platelet count. So you're doing
Yes, ma'am.
CBC with PT, INR, and platelet count and TEG. Okay.
Yes, ma'am.
And you should be able to explain if the examiner asks you why you want to get an L and what in LFT will you get done.
Yes.
So this is a liver case. So all this detail of LFT you should be able to explain. You'll get a total bilirubin, you'll get a direct and indirect, what are the changes that can be seen, what enzymes do you want done. You will also have all viral markers. You've not mentioned viral markers here. She's
Yes, ma'am.
already hepatitis C positive, so viral markers are a must. Okay, then urea, creatinine, everything in detail, serum electrolytes, particularly serum sodium.
Sodium.
Serum
Yes,
sodium.
ma'am.
So you should be able to explain all these features as to why you need to get each of these investigations done. Okay.
What do you expect in this patient?
Yeah. So did this patient have these investigations since you saw this patient in the emergency and you saw
Yes,
her the
ma'am.
day later again?
Yes, ma'am.
So do you have those findings with you?
Yes, ma'am.
Okay. So she has a hemoglobin of 9, a platelet count of 84, a total bilirubin of 2.6. She has enzymes raised. Her total protein is good, although her serum albumin is also good, 3.8. Anything else? Did she have an ECG, an X-ray?
Yes, ma'am.
Okay. Urea, creat, electrolytes, fasting blood sugar. Glycosylated hemoglobin is slightly on the higher side. Her
Yes,
INR is 1.6. Okay. So based on this, can you put her in any child criteria? Can you go back to your child criteria slide?
Yes, ma'am.
Can you put her on, if the examiner now gives you these, the examiner can give you random values, please, for the
Yes,
students
ma'am.
listening in, because these values are usually not available to you in the exam. The examiner can give you random values, and because you have this chart with you, which you've memorized, you should be able to categorize your patients depending upon whatever investigations are told to you. All right?
Yes, ma'am.
So can you put your patient into this category now?
Yes, ma'am. There was no encephalopathy, so it will be
Okay.
1 point.
Okay.
Ascites was mild to moderate,
Okay.
and so it was 2 points. The
Okay.
bilirubin was 2.6, which comes again 2 points. Albumin was 3 point, more than 3.5.
Okay.
So first,
Till now we have 6, and PT INR was 1.6.
1.6, ma'am.
So it's almost 7.
So yes, ma'am.
So
So it
class
comes in.
B.
Yes, ma'am.
Okay, so
You can
this
classify.
all the students should be able to do, calculate the entire thing, and this is about 7 to 8 or whatever it turns out, and it's class B.
B.
Okay, go back to your investigations. Are you happy with this INR of 1.6, or would you accept your patient for anesthesia at this INR, or do you want to correct it to any figure?
Ma'am, I would like to get it further evaluated before
How do you
giving
want
any
to
correction.
evaluate? You have a
I would.
TEG, you have
Yes, ma'am.
INR, you have platelet count. What more do you want?
Ma'am, with the help of tag, we can actually define the exact.
Did she get a TEG done? Because we know
Yes,
that
ma'am.
the TEG is available in our emergency and our ICU.
Yes, ma'am.
Let's see. Okay.
Yes,
Oh, this looks like a normal graph to me.
yes, ma'am.
Right. Okay. So with this normal, so that means if you have, what you're saying is if you have the facility, you get the TEG done in spite of having an INR and a platelet count.
Yes,
And
ma'am.
if the TEG appears normal, now would you want to get the INR changed?
No, ma'am.
No. Okay. So 1.6 is acceptable in this patient because the TEG is normal. The old criteria of correcting INR at 1.5 with FFPs is no longer valid. It is outdated because studies have shown that infusions of large amounts of FFP do not correct the INR to below 1.7. So up to 1.7 is acceptable provided the TEG is correct. And in patients who do not have a good, have a dysfunction shown on the TEG, particular component therapy, whether they require cryoprecipitate, whether they require FFP can be given. Would you like to give this patient vitamin K?
No, ma'am.
Okay, I would defer. Probably vitamin K can be administered, although there is no objective evidence of obstruction. But as I said, this patient may have chronic anorexia and dysfunction due to malabsorption of vitamin K. That time, because of the nutritional deficiency, you may like to add it for your preoperative preparation.
Yes, ma'am.
Okay. Now, you accept this patient as it is. You don't want any major changes. The ECG X-ray was okay.
The
Okay.
X-ray was okay, ma'am.
Some amount of diastolic dysfunction.
Yes, ma'am.
ECG showed tachycardia, no rhythm disturbances.
No, ma'am.
Okay. Now, what pre-op? Now, this patient is posted to you for an incisional hernia.
Yes, ma'am.
Will you tell the patient, do you want to talk to the surgeons whether it is laparoscopic or open, or would you prefer anything out of the two?
Ma'am, I would like to talk to the surgeons because we would actually.
They say कि हम तो laparoscopic ही करते हैं. Would you be happy? Accept it?
Yes, ma'am, because laparoscopy will actually help our patient more. There will be a reduced time for recovery, and even
So
the
per se ascites or the presence of liver dysfunction or the presence of cirrhosis is no contraindication to laparoscopic surgery. All the advantages of laparoscopic surgery, which the surgeons say exist, they are also applicable to these patients. So there is no problem provided the abdominal pressures are not more than 12. Okay. Then surgery under laparoscopy is acceptable. So what preoperative orders would you like to give for this patient who is now posted for a laparoscopic incisional hernia repair with these investigations?
Ma'am, first of all, I will request fasting of at least 8 hours for solids and liquids, as these patients may be
Please
prone.
do not feed these patients liquids 2 hours prior. These patients, she has a hernia, and even if she didn't have an incisional hernia and was for any other, say, lap poly, these patients have a full stomach. They have a gastroparesis. They have reduced peristalsis. They should not be fed 2 hours prior to surgery. Please keep them fasting overnight. Okay, they are high risk for aspiration. They are what are known as full stomach patients. Do not feed them water 2 hours prior. Okay?
Yes, ma'am.
So overnight fasting.
Yes, ma'am. I would request for an informed consent to be taken for surgery and anesthesia.
Right.
As she's a diabetic, we'll prefer to omit her OHAs, and she should be.
Would you like this patient should be shifted to insulin, please?
Yes,
She's
ma'am.
on metformin and glimepiride, I think, and her glycosylated hemoglobin was 8.5. Would you like her?
Yes, ma'am.
Okay. Okay. So we will not go into the diabetes, otherwise we'll completely divert from our topic. But this is one patient who's got comorbidities, who's not very well controlled, and who's undergoing a major surgery with prolonged periods of postoperative fasting. All these are indications for shifting her from oral hypoglycemic agents to insulin.
Yes,
so once you shift her, the insulin regimen will be as you manage for a diabetic patient. We'll not focus on that.
Yes, ma'am.
What else? So fasting, consent, you like to arrange something?
arrange blood products
Blood and blood
Type and
products.
cross-matched blood,
Okay. What else?
along with
And,
cryoprecipitates also. Okay.
Okay.
yes,
Okay. Any
and
other pre-op orders?
aspiration prophylaxis, ma'am.
Okay. What else?
And we will avoid giving any sedation, benzodiazepines.
So this
In
is
this
one
case.
patient on whom benzodiazepines, we will come to drug pharmacology. Benzodiazepine sedation is absolutely not required and not
Yes.
recommended. Okay. What else?
And as for the diabetic protocol, we can ask for
Okay,
morning
you forget
sugar and
about the
serum.
diabetes. What else?
And
Would you like to give her, tell the surgeons in the morning to, or make sure that she has some antibiotic prophylaxis?
yes, ma'am. Antibiotic prophylaxis, because she'll be
Okay.
prone to infections. So
And
Will be immunocompromised and she is having ascites. So there is a risk of spontaneous bacterial peritonitis. Okay.
yes,
That is
ma'am.
in your mind.
okay, blood grouping and cross matching, adequate blood, and whatever we need to do for diabetes, that is, get a morning fasting blood sugar and the works for diabetes.
Yes, ma'am.
Okay. Now, you've arranged for blood products. You have not corrected her INR before this. I don't. Did her ascites need any draining preoperatively?
No, ma'am.
Did she have any bit of effusion, pleural effusions?
No,
Minimal.
ma'am.
No. Her
Minimal.
PaO2 preoperatively was okay.
Yes, ma'am.
Okay. So everything is acceptable. Now you have to give her anesthesia. You've given the pre-op orders. What is your choice of anesthesia and how will you manage her induction and maintenance? She's for an incisional hernia surgery laparoscopically.
Yes, ma'am. My choice of anesthesia will be a general anesthesia, ma'am,
Okay.
with endotracheal intubation with
Okay.
controlled mechanical ventilation.
Very good.
And I will prefer doing an RSI with
Just say it's complete.
Do not use these abbreviations like RSI and okay.
I will prefer doing a rapid sequence in induction, ma'am, with
Okay.
succinylcholine.
Because she has an incisional hernia.
Yes, ma'am.
Plus
And
ascites.
plus ascites, but in
Yes,
these
ma'am.
all patients of liver disease are not to be taken for RSI. If she did not have ascites, if she did not have an obstructed gut, maybe we could have taken her for a normal induction and not done RSI.
Yes, ma'am.
Okay. So what monitors will you put?
All standard monitors like BP, blood pressure monitoring, saturation monitoring. We will take end-tidal carbon dioxide monitoring, electrocardiograms.
ASA recommended monitorings you should put in these patients.
Yes, ma'am.
Would you like to catheterize her bladder?
Yes, ma'am.
Okay.
We prefer
Also
cathetering
like
because
Under all aseptic conditions. Okay.
under all aseptic precautions, after induction of anesthesia, you should get her bladder catheterized. Would you like to put in an arterial line in CVP?
yes, ma'am. Arterial line will be beneficial for us, ma'am, in this case, as these patients are they are we don't know the fluid status, and they might intraoperatively the surgeons might drain a large volume of ascites. So during that period, it will give us an exact idea of
Yes.
what the
It
blood
will give
pressure
you
is.
a rapid idea about the hemodynamic status and intravascular
ma'am.
volume status. The blood pressure will be monitored more diligently.
Accurately.
Okay,
Yes,
and
ma'am.
also it can be used for doing blood gas analysis intraoperative.
Yes, ma'am.
Okay, for child A, you may not require. For child C, you definitely require. And for child B, it depends upon your clinical scenario. How well the patient is compensated or not compensated, what surgery she's undergoing, what is the expected fluid imbalance during the surgery, is she likely to require blood or transfusions or not, what was her INR. So in this child B, it is as well as a clinical decision. Okay, so you may like to put these. Now, tell us about the drug pharmacology changes. What drugs would you like for induction of anesthesia? What all will you give her? She's on the table. Monitors have been attached. Can you proceed with your anesthetic induction?
Yes, ma'am.
And for all the students listening in, please, you do not induce patients. You induce anesthesia, right? So you must say not for induction of patients, but for induction of general anesthesia. Okay.
In the drug pharmacology, ma'am, all the drugs basically they're factors which affect their hepatic clearance. It depends on the blood flow to the liver
Right.
and the free fraction of the drug present in the circulating volume. So,
What are
and
the factors which decrease the blood flow of the liver now after induction? Can you just enumerate? You've mentioned this.
ma'am, factors, it can be our anesthetic agents, which will decrease the volume. Intraoperatively, it can also be due to the excessive bleeding,
So hemorrhage,
hemorrhage.
induction of anesthesia itself because of vasodilatation.
Yes, ma'am.
Yes.
And splanchnic vasodilatation, you will have a reduction in the arterial blood pressure. Then opening of the abdomen,
Abdomen.
use
And
of
a retraction of
retractors,
the
use of retractors,
Yes,
use
ma'am.
of IPPV,
Yes,
and
25%.
hypocapnia.
Yes, ma'am.
All these factors will reduce the hepatic blood flow. Okay. So induction.
And also the use of here we can discuss the induction agents also.
Yes.
You'll be using induction agents, so there will be some effect on hepatic auto blood flow regulation. So what is normal hepatic auto blood flow regulation? What is HABR?
Ma'am, it is the regulation is when the supply with the portal venous system is decreased, there is a reciprocal increase of the hepatic
Arterial blood supply. Yes.
So this helps in maintaining the perfusion, liver perfusion, whenever depending on the various causes. It can be mechanical or neurological again.
Okay. And talking about our inhalation agents, how do they impact HABR?
Ma'am, it's HABR. They decrease all of them most.
Except for halothane, all of them maintain HABR. Okay. So they can
Yes,
be safely used except for halothane.
yes.
Okay.
So basic changes in drug pharmacology, when you mention the systemic manifestations at that time also, the examiner can ask you, they can ask you at this time, and the altered pharmacokinetics and dynamics, both you should be able to enumerate. So increase in the volume of distribution, increased fraction of active drugs due to decreased synthesis of albumin, reduced synthesis of enzymes like pseudocholinesterase, and decrease in clearance. All these have an influence on your drug pharmacokinetics. Okay. Now, what induction agent will you prefer?
Ma'am, I will prefer propofol for this case. We will administer propofol in reduced doses because they might be the volume of distribution is actually increased, but the protein binding there is a reduced proteins, so the protein binding is decreased. So that
The fraction of the drug may be higher. So
yes,
although the volume of distribution is higher, so otherwise propofol and thiopentone would be required in normal or higher dosage. But because the albumin in those patients where the albumin is low, you will have a higher free fraction of drug available. So you should give in carefully titrated dosages.
Yes, ma'am.
Otherwise, propofol is a safe drug to give.
Yeah.
Yes.
So administration should be done. Okay.
Yes.
Slow titrated administration of the induction agent. So you will give propofol. How much? What is the weight of this patient?
The way she weighs 78 kgs, ma'am.
Okay. So how much propofol would you like to give?
Ma'am, I would like to give around her lean body weight was calculated to be around 50 kgs. Okay. So I can initially start by 1.5 mg per kg. So
2
approximately
per kg is okay.
That was
because you're giving a lean body weight. So okay. Then following induction, what opioid would you like to give to this patient?
Opioid, ma'am, we would ideally prefer remifentanil, but it is not available in our
now remifentanil is available. So good thing about this is that now remifentanil is available. So because remifentanil is extremely safe. Why?
Because, ma'am, there is no hepatic metabolism. It is metabolized by red cell esterases, which is not hampered by any hepatic.
Absolutely normal in advanced liver disease also. So it's a very safe drug to give in these patients. If you don't have remifentanil, like most of us don't as yet,
then, ma'am, I would prefer fentanyl.
Okay. Fentanyl is again a safe drug to give. You should remember hepatic metabolism of drugs takes place in 2 phases, the phase 1 and phase 2. And the phase 2 of glucuronidation is not destroyed till very advanced liver disease. Okay,
Yeah.
so drugs such as fentanyl remain quite safe till the advanced stages of liver disease. This is a patient of child B. So fentanyl can be very safely given. You may, repeated doses may be reduced, but initial doses of fentanyl are safe, remifentanil are safe, but morphine will have prolonged half-life. Okay, so morphine is a drug which you probably should avoid in these patients. So you can give her fentanyl, then you can give her propofol. Then what next?
Muscle relaxant, ma'am. As we were initially we were doing rapid sequence
Okay, so you want to proceed
induction.
with rapid sequence. Should you not have pre-oxygenated your patient then?
Yes, ma'am.
So when you brought her to the theater and you put her on the table, attach the monitors, you should have pre-oxygenated her
Yeah.
while, yes, so that you missed out, okay? If you're actually planning RSI, so take a couple of seconds to plan your answer and say, I would pre-oxygenate the patient, and then the examiner can ask you how you will pre-oxygenate with a tight-fitting mask, with so much flow of oxygen, 100%, okay? So you can pre-oxygenate her, then give her fentanyl, then give her propofol in that dose, and then do you want to do a modified RSI?
Yes, ma'am.
Okay, so will you do a brief check ventilation, and what drug do you want to give her for RSI, for intubation?
I'll give a succinylcholine, ma'am,
Okay,
at a dose of 1 milligram per kg.
okay.
And
So advanced liver disease will have pseudocholinesterase deficiency, although mild and moderate diseases may have normal pseudocholinesterase level. Advanced level will have a deficiency, and then you must reduce the dose of succinylcholine. Okay.
One thing in monitoring which we missed is the application of neuromuscular monitoring, which is a must in these patients.
Right, right.
So actually from beginning, it should be systematic just for your benefit so that you don't skip on any important piece. Okay.
Okay. Any other muscle relaxant? Can you have an RSI with a non-depolarizer?
yes, ma'am, there are few studies which mention we can use atracurium at a greater dose of almost 1 milligram per kg.
Okay. Can
Which will,
achieve muscle relaxation fit for intubation in how long time?
ma'am, approximately around 90 seconds.
Okay. Okay. Cisatracurium also?
It is not mentioned in the guidelines of
So
RSI,
generally,
ma'am.
RSI, the replacement for scoline is usually rocuronium.
Yes.
But rocuronium would not be an appropriate drug to use in this patient of advanced or moderate liver disease. So yes, in those conditions, probably where you may not like to use choline for various reasons, maybe the potassium is higher, maybe the patient has prolonged immobilization, there are other reasons why you would like to avoid choline. At that time, atracurium in a higher dose of 1 milligram per kg can achieve intubating conditions in 90 seconds. Okay. But moderate liver disease, you can, if you want, go ahead with succinylcholine. Okay. So you will give 1 milligram per kg succinylcholine. Okay. Achieve good intubating conditions, put in an endotracheal tube, inflate the cuff, connect to the ventilator, and check for maintain a normocapnia. Okay. Did you plan anything for the pain relief of this patient?
Yes, ma'am. I can either go for a local infiltration at the end of surgery.
Okay, we'll come to that. Okay. First, now that if you have used choline, what other muscle relaxant would you like to now give?
I would like to give a cisatracurium, ma'am.
Okay, atracurium or cisatracurium, which remain the safest. Remember, vecuronium should not be used. And as Dr. Upma has very rightly mentioned, whatever drug you give more than it's important that you monitor the effect. So the muscle relaxant should be done under neuromuscular monitoring. So one question has just popped up: why rocuronium can't be used?
Ma'am, they are steroidal neuromuscular blockers.
Yes.
They are mainly metabolized by the liver. So in
Not
condition,
recommended because it will have a prolonged duration of action.
Yes,
although we now have some safety because now Sugama Dex is available with us, but it's not a prime. With the availability of atracurium and cisatracurium, rocuronium is not an appropriate drug to be used for patients with moderate or severe liver disease. Okay. What about the inhalational agents?
in inhalational agents, I would like to I would prefer desflurane
Okay.
or
So the
sevoflurane.
best agent to give in these patients, if you have, is desflurane. Why?
Ma'am, first of all, there is a it preserves the hepatic blood flow, and
Okay.
also there is minimal fall in the cardiac output,
Okay.
and also it's least metabolized in the liver,
Okay.
and rapid
Metabolism is the
excretion.
minimum. So isoflurane and sevoflurane can also be used, but desflurane, because of its minimal metabolism, is the best drug to give. It maintains the hepatic blood flow also. Then the examiner can ask you the metabolism of all the inhalational agents. There is a small hack to remember this.
Yeah.
Halothane, 20%. Isoflurane,
2%.
2%. Sevoflurane, 0.2%. And desflurane, 0.02%. I think, is that correct, Upma, if I
Yes,
remember
yes,
it right?
ma'am.
So this
Yes.
is in the value given in
1/10 of
textbooks is just thoda sa aage piche, but it's an important, in these multiples of 2 you can remember, you will be mostly right and you will not go completely off track. So that's an important hack to remember, the degree of metabolism. So the ideal drug to give would be desflurane. Okay, so maintenance on oxygen and air, or oxygen nitrous oxide and desflurane, atracurium or cisatracurium as the muscle relaxant of choice. Propofol and fentanyl can be safely given. If you have remifentanil, that is the best drug to give. What about, as we said now, pain relief for these patients?
Ma'am, I can give a paracetamol. I will give paracetamol.
Okay, so
But
is the acetaminophen contraindicated in these patients?
ma'am,
or is it completely safe? Just tell.
it is not contraindicated unless it is solely the cause of hepatitis.
Yes.
Okay.
And it is usually administered in reduced doses.
So that is the caveat, that it should be administered in reduced dosages. It's not contraindicated. And maximum dose recommended in adult patients is 3 grams per day.
Yes, ma'am.
Not more than that. Can you give non-steroidal anti-inflammatory agents also to these patients?
No, ma'am, I wouldn't prefer not to give.
Why? Why?
Because, ma'am, these patients already have thrombocytopenia. They are prone to upper GI bleeds, which can be precipitated with the use of NSAIDs. And mostly they are also nephrotoxic. So these
Yes.
patients in the
They
post-operative
are
period.
nephrotoxic. They can lead to upper GI bleeds, which are already a complication in these patients. Plus, they have effect on platelet function,
Yes, ma'am.
which anyway is defective in these patients. So NSAIDs should completely be avoided. So what have you planned for the pain relief of this patient?
Ma'am, I can further, I can give a bilateral tab block if for pain relief, or we can go for local infiltration also.
Would you like to give a
With the
top
localized.
tap block with an INR of 1.6, 1.7?
Ma'am, somebody is asking about epidural in the
Okay, in the chat box, right? We'll talk about that. So would you like to give, as somebody's already pointed out, would you like to give her an epidural?
No, ma'am.
Since she has a deranged coagulation, she's already 1.6, 1.7. We've accepted her on that. It is preferable, if the platelet counts are low and the INR is deranged, to avoid central neuraxial block. Post-op to bilkul nahi dena, because intraoperatively blood loss and coagulation will vary. So unless you're very sure of the coagulation profile, you should not touch the neuraxis. Now, better options are available to us. We have peripheral blocks which can be given under ultrasound guidance. I would recommend all the students to please read regional anesthesia and coagulation and anticoagulation, and the relationship between what level anticoagulation is present and what options of regional anesthesia you can give. But as of now, the rules for central neuraxial block also are applicable for peripheral nerve blocks. Okay. However, because in this patient, the INR was 1.6, the platelet count was more than 80,000, the TEG was normal, probably you can go ahead and give a tap block. I will accept that you give her a bilateral tap block. Would you like to add an additive to this to make it long acting?
Oh, yes, ma'am. I will add dexamethasone, ma'am, by
Okay.
0.1 milligram per kg.
Okay. Would you like to give clonidine or something to this patient?
I will not give clonidine, ma'am, because it's an
Remember, alpha-2 agonists will interfere with liver blood flow. So that's not
yes,
a very good drug to give, although systemic absorption is less. But the problem with dexamethasone, can you eliminate one problem with dexamethasone in this patient?
ma'am, she's a diabetic,
Yes,
so
she's a diabetic. So
Might
that
have.
might produce, if her diabetic status is not very well controlled, it may not be a very good drug to give.
And what about the dose of local anesthetic in this patient? That is also an important thing.
yes, ma'am. Local anesthetic dose is uh, the
It will be reduced. It will be
yes,
reduced
ma'am.
by
Dose will
approximately 20 to 30%.
percent, and
And because
so
it is going to be facial plane block and large volume of local anesthetic will be used, so you are required to give low concentration of local anesthetic, and the total calculation of dose will be reduced by 20 to 30% because of hepatic abnormality. Okay,
yes,
so
ma'am.
keep these things in mind while you are giving regional anesthetic.
So you can plan a multimodal analgesia for her.
Yeah.
You can give her paracetamol in reduced dosages. You can give her local infiltration with local anesthetics. You can give her a tap block.
And there is a
You
small
can give
question.
her IV PCA also.
You can, the other option is
Yeah.
for since fentanyl, and now we have remifentanil, IV PCA, in case there is a coagulation abnormality, IV PCA is an
Is
extremely
the
good
only choice.
option
Yeah.
for managing the pain of these patients. Pain needs to be managed because all the hypoxia, that hypercarbia, and all the problems of inadequate pain relief could get multiplied in her. So you need to make sure that you do give her good pain relief. Now, intraoperatively, while the surgeon is continuing, suddenly you find that her saturation begins to dip.
Yes,
And
ma'am.
there is onset of hypoxemia. The saturation, which was initially 96, has suddenly come down to 90, 91. What can be the probable causes?
Ma'am, it can be due to the shunts, precipitation of shunts. There is
सबसे
increased
पहले कॉमन चीजें बोलना है ना?
bleeding. Yes,
ऑक्सीजन
ma'am.
चेक करना है,
Yes, ma'am.
कनेक्शंस चेक करना
Check
है,
करना.
सैचुरेशन प्रोब चेक करना है कि प्लेथ आ रहा है कि नहीं, इज द सैचुरेशन प्रोब शोइंग यू द करेक्ट वैल्यू, इज द सर्किट इन प्लेस, या द कनेक्शंस इंटैक्ट, इज द ऑक्सीजन फ्लो ओके. Do
Yes, ma'am.
not, just because your liver disease does not make you fixated on avoiding the common causes of hypoxemia.
Yes,
Then
ma'am.
you go on to conditions which are more particular in this patient. Can she have bronchospasm? Could she
Yes,
be
ma'am.
in a lighter plane of anesthesia? All that can
Yes, ma'am.
also produce hypoxemia, no? What else?
It was
And
a laparoscopic surgery, no?
Laparoscopic surgery हो रहा है ना, तो उससे भी related features आपको याद करने. You auscultate, is the peak pressure going
Yes.
up? What is the abdominal pressure? Does she have bilateral air entry equal? Does she have bronchospasm? Pneumothorax तो नहीं हो गया,
yes,
है ना?
ma'am.
Then you go on to all this which you are ready to
Yeah.
charge
Charge.
with us for the, I think you're trying to say hepatopulmonary syndrome.
Yes, ma'am.
Okay, so did she have any pleural effusion? You'll auscultate.
No.
Has the ascitic fluid gone up with into the chest? Did she have any hydrothorax? And then comes the role of hepatopulmonary syndrome, that because of the shunting which was present could have precipitated hypoxemia. Okay. Similarly, if your examiner says that suddenly this patient has developed hypotension, don't just jump onto the liver causes. All the causes of hypotension in a normal patient should also be elicited.
Yes.
Okay. Bleeding to nahi ho gaya, fluid to nahi kam ho gaya, inhalational agents to zyada nahi de diye. Then you think about liver specific causes.
Yes.
Okay. Now, what intraoperative monitoring would you like to do in this patient? Intraoperatively now, continue.
Ma'am, blood loss and continuous urine output monitoring,
Urine
ma'am.
output. So don't start with blood loss. Start with ECG, heart rate. That's
ECG.
continuing, no? A
Yes,
continuous ECG, heart
ECG,
rate,
heart rate
and
monitor.
you have now invasive blood pressure. You had put in
Temperature.
invasive line, invasive blood pressure, temperature. We
Temperature
missed out on
monitoring.
temperature, urine
Neuromuscular
output.
tract.
Okay, you have
NMT, ma'am.
ETCO2,
Yes,
and
ma'am.
you have monitoring of
Neuromuscular
the
transfer.
neuromuscular monitoring. Okay,
And
and
also add,
if you have surgeries where there is a large blood loss, if you have surgeries where there is a lot of fluid shifts, she could be undergoing some cancer surgery, she could have had a hemicolectomy, any of these surgeries, if you have, since you have TEG at your institute, you can have an intraoperative TEG also as part of the monitoring.
And
Okay.
intraoperatively blood sugar.
Yes, blood sugar.
And
Just going to
arterial
say
blood.
intraoperatively, blood sugar. She's a diabetic patient. Even if she was non-diabetic, you would continue to monitor the blood sugar on an hourly basis for her.
yes, ma'am.
Okay. Now, what about the post-operative complications that or post-operative care that you should give to these patients? Would you like to extubate her on table, extubate the trachea?
Yes, ma'am. If the ABG was fine and there were no any complications intraoperatively, I would, and the surgery was uneventful, I would prefer going for an extubation.
Okay, the trachea can be extubated provided everything is okay. There are no surprises here. You may be wanting to extubate the trachea on table. Would you like to shift her to the ward or an HDU?
No, ma'am, I'd prefer an HDU or an ICU.
You prefer an HDU where monitoring can take place. What complications can occur post-operatively now?
Ma'am, post-operatively, she might have coagulopathy again, and bleeding disorders can happen.
Okay.
And they are prone to infections, so post-operatively she might have infections which might lead to sepsis, spontaneous bacterial peritonitis, or even pneumonia.
Okay.
And
so she's
might
immunocompromised.
Hepatic encephalopathy.
Yeah, she is immunocompromised. She can have any wound infection. She can have pneumonia. She can have spontaneous bacterial peritonitis. Coagulation dysfunctions can set in. Most importantly, you have to keep a hawk's eye on the urine output.
Yes.
She's a likely candidate who can develop hepatorenal syndrome. So urine
or
output,
AKI even.
AKI. So these patients have to be very closely monitored for the urine output. Of course, the vitals you will monitor, the temperature and everything. But urine output and her mental status.
Should be assessed
hepatic
regularly.
encephalopathy can set in with all the infection and blood transfusion and everything that you've done. So very clearly you have to monitor her consciousness status, her urine output and everything else so that these complications do not develop. Hypothermia doesn't develop post-operatively.
Because it will increase the risk of bleeding and further complications. Okay?
Yes, ma'am.
And one more thing, ma'am, although these patients are having prolonged INR, that doesn't make them less predisposed to development of thrombosis, venous thrombosis. So mechanical thromboprophylaxis should be started intraoperatively as well as continued postoperatively, because we
very valid point.
We are a little skeptical to start this patient on anticoagulants. Antithrombotics and anticoagulants in the postoperative period. So this also needs to be kept.
Absolutely. So all that we had talked about, the rebalance of the hemopoietic system where these patients have procoagulants getting disturbed as well as anticoagulants getting disturbed. At that time, these patients do still have a risk. She's obese, she's overweight, she has stasis, she can have the tendency to develop thrombosis, and it actively must be managed in the postoperative period.
And somebody is asking, there are 2-3 questions regarding CVP line, whether we'll be putting CVP line in this patient or not.
Okay, would you answer that, Navneet?
Yes, ma'am. In my case, it was classified as a CTP grade class B. So there is no any absolute indication for a CVP in my case. So I would not prefer it.
You don't want to put it? See, as we said, class B is more of a clinical indication. If you feel that there are going to be too many fluid shifts, if you feel that the patient might require CVP in the postoperative, you might require nutritional support in the postoperative, there are going to be blood transfusions. In those conditions, you can put CVP. In class C, definitely it will be required, but in class B, it's more of a clinical indication. So as per case basis, you can put CVP or not.
And now you're having ultrasound, so it can be an atraumatic insertion of CVP under ultrasound.
Must be put under ultrasound guidance.
Yes, ma'am.
Okay, so you can extubate the trachea, shift the patient to the PACU and then to the HDU and maintain that normal Monitoring, which you had done intraoperatively, must continue. We've already outlined whatever post-operative concerns can be had in this patient. And pain relief should continue. Monitoring for blood glucose continue. The antibiotics, third generation cephalosporins should continue. What is the commonest cause of spontaneous bacterial peritonitis, Navneet?
Ma'am, E. coli
Okay, good.
and
E. coli and
Klebsiella.
Klebsiella, very good. So you must make sure that that these organisms are the ones which are taken care of in the post-operative period. So we've basically done most of the questions that can be asked in this case discussion. If there are more questions in the chat box, Dr. Madhuri, we can answer them. Some we have taken along the way, the rest we can answer if there are any significant questions. Thank you so much, Navneet.
Thank you, ma'am.
Can we go ask the MCQs, ma'am?
Yes, of course, Navneet. We've created
Yes,
a few
ma'am.
MCQs. Will you show them so that madam can ask them? Right, over to you, Dr. Madhuri.
Yeah, thank you very much. So the first MCQ, model for end-stage liver disease includes all of the following except serum bilirubin, serum creatinine, serum albumin, and international normalized ratio. Wow, even before I could finish, the answer is there. C, serum albumin. This is a common answer.
Yes.
Is that right?
Yes.
Okay, good. Next question. Next question. Based on recent evidence, identify the correct statement with respect to cirrhosis of the liver. Administration of FFP routinely to correct INR is advisable before all the surgeries in cirrhotic patients. Patients will have increased levels of both procoagulant and anticoagulant factors. Administration of FFP can correct INR less than 1.7, and thrombocytopenia is a surrogate marker for cirrhotic cardiomyopathy. So the common answer is B.
Yes.
Patients will have
They've been listening to us carefully.
Yes, credit goes to your team. Okay, next question, Navneet.
Yes.
Question 3, Navneet. Yes.
Child-Turcotte-Pugh criteria is used to stratify surgical risk in cirrhotic patients, considers arbitrary values for lab parameters. Grade C indicates good prognosis and is a good measure for mortality outcome in compensated cirrhosis. So there is B, C.
You have to answer in A if all the statements are correct. B, all except 3 are correct. C, all except 3 and 4 are correct. And D, if option 3 is correct.
So most of them have gone in for B.
Which is correct.
Which is correct.
Okay, so all except 3, that is grade C indicates good prognosis is not correct.
Yes.
Okay. The next question, the opioid agent of choice for cirrhotic patients is fentanyl, alfentanil, morphine, remifentanil.
Yeah, so you have a quick answer from it.
D. Remifentanil. Okay.
Because it is the agent of choice now.
Yes. Next question. Development of any of these indicates decompensated cirrhosis. Ascites, fever, impaired test of coagulation, and hypoalbuminemia. So some are saying A, some are saying D. What is the correct answer?
A.
Ascites. Okay. Okay.
There were a lot of questions. Thank you. There were a lot of questions in the chat box.
Yes. There are many questions in the chat box. Shravani, just forward the questions to ma'am. Those which have not been answered. Only those which have not been answered.
And someone has asked that whether based on the TEG derangement, how can they correct the INR of the patient?
Upma, would you like to answer that?
Yeah, basically you have to see if the reaction time is prolonged or if the strength of the clot is not there. So accordingly, you have to take the call for transfusion of platelets or the cryoprecipitates.
Okay. Go on to the next question.
Ma'am, with high INR, whether arterial line can be feasible or not?
Yeah, I think in expert hands it can be safely put. We'll be catheterizing only the radial artery, and routinely in cardiac surgeries,
You
the
would
patient.
not be taking a patient with extremely deranged
Yeah.
INR for surgery. You would have created an INR which was acceptable to the surgeons before they put the knife on the patient. So at that point, you can put an arterial line because it's a peripheral line, most important, and it is amenable to compression. With extremely deranged INR, of course, you won't do it. But in an INR where surgery is acceptable, at that INR, where you have accepted the patient, you can, it may be higher than normal, you can put an arterial line because it's peripheral and it is amenable to compression. Do not put it without doing the Allen's test. That is applicable for all arterial lines.
You
Modified
can
Allen.
also take help of ultrasound for putting arterial line.
Absolutely. That
Radial,
really has made
radial
our
you
life
will be
much
preferring.
safer. Yes.
Ma'am, role of magnesium in multimodal analgesia.
Out of course, I would say, but it has its own role. There are a lot of studies which are for and against, depends upon the dose you are using it and in which form you are using it. It has been used in peripheral nerve blocks, it has been used in epidural, it has been used in spinal, it has been used n number of places, and the results are variable. So I don't think I should say anything more related to magnesium here in context of liver disease. Please go for tried and tested things. It's safer that way.
Ma'am, someone has asked whether opioid analgesia infusion can be given post-operatively.
Yes, of course. You are shifting the patient to HDU, no? So HDU is a monitored place. With monitoring, you should give opioid analgesia. It's absolutely safe with remifentanil, even with fentanyl infusions. HDU is a good enough place and you should give these patients opioid analgesia.
And it has also been mentioned that you can give infusion of IV local anesthetics also for pain relief, but that has, you again have to take care of the dose. It should not be overdose because especially with multiple doses or infusions, there are chances of drug accumulation with the end stage or chronic liver disease. So you have to be cautious. It's a thin wire kind of
it's
situation.
a thin line, and in patients who are sick or decompensated, things which you normally would get away with normal patients, experimental stuff should not be tried. I don't recommend that. For students particularly, please stick to what your textbook says. Do not go for what the latest article has said and what some study has said. Please stick to what your textbook is saying. Okay? Right.
Ma'am, which local anesthetics will be safest for these patients?
Both lignocaine, bupivacaine, ropivacaine, any of them can be used. Do not exceed the maximum allowable doses for these. The dose of the local anesthetic depends on what you want to achieve with it. Would you want to give it for a patient who had a central neuraxial block for some reason and you want to achieve motor block? Do you only want to give it in the central neuraxial block for epidural for pain relief? Do you want to give it in the peripheral block? Do you want to give it in the tap block? That decides which drug to give and what concentration to give. But as long as you do not exceed the total recommended safe dosages, any of these drugs can be given depending upon whether you want to achieve motor block or sensory.
Thank you.
I think there's one more question there, Shravani. Any indication for fentanyl patch?
Yeah, it is. It can be safely given. Yes.
Can be safely used.
And can we give epidural on the basis of thromboelastography?
Yes, you can.
I think this was discussed.
Yes, this has already been discussed.
Okay. And what about giving a tap block for mesh plasty?
Okay, tap block for mesh plasty. You're not giving the tap block after the mesh plasty because tap blocks are better given prior to disruption of the planes. It is a laparoscopic surgery, and plasty under laparoscopic surgery will work well with tap block. But my recommendation is that all the tap blocks should be given pre-operatively before the abdominal planes are disrupted, even if it's a laparoscopic surgery.
Ma'am, frequency of INR and LFT post-operatively, daily or alternatively?
Frequency of measurement.
Measurement of INR and LFT
frequency of measurement has got nothing to do with pre or post-op. It's got everything to do with the amount of disruption that has been caused.
Yes.
What was the preoperative INR? How much of blood loss or disruption has taken place intraoperatively? How much of components you have given intraoperatively? What is the status post-operatively? If it is it's a very variable range where there is a lot of drugs being, a lot of components being given, then you probably need to do it more frequently. If it is stable, you may get away with doing it just once a day. There can't be a blanket answer to this this question. It depends.
It will depend upon the surgical nature of surgical intervention that has been performed.
The amount of components you have given, the baseline, the response of the patient, the surgical intervention, everything will decide the frequency of monitoring.
Ma'am, another question. Comparing with sevoflurane and isoflurane, which one is preferred?
It is traditionally said that isoflurane maintains the liver blood flow best, other than desflurane. Anything more?
Madhu?
Yeah, I think somebody is asking, can epidural morphine be given?
Epidural?
Morphine.
Yes, of course, morphine can be given, only its duration will be longer. So depends upon how long you want the pain relief, where the patient is being monitored. Morphine will have a longer duration of action. So probably you can reduce the dose, and that will also have a longer duration of action. As long as you're monitoring your patients, longer pain relief is good. No? So yes, you can give morphine.
Okay. So I think the question bank is over. So now can I shoot one question at Dr. Navneet?
Yes, please.
I think Bajwa sir is here. I think Bajwa sir is here. If he wants, let him ask. Then
Yes,
I'll ask.
yes.
I will ask the question to Dr. Ranju, not to the PG student.
I will ask to Navneet.
Yes, please go ahead, Dr. Madhuri.
See,
Okay.
one of the myths about the liver cirrhosis is the metabolism of the drugs. Now we are giving the anesthesia drugs. We know the very hepatic damaging effects of these isofluranes or Civo or whatever the other drugs we are giving to these patients. Now we always watch the acute effects. I think immediate 2-3 days when the patient is in the operation, in the recovery and the ward. Have we ever studied the long-term effects of these drugs over the next 6 months to 1 year? Because I was searching for those studies because the follow-up is very essential. These patients do give a follow-up in the surgical OPDs. And we anesthesiologists are never involved in knowing the long-term effects, not here, even in the European countries or American countries.
Right.
People are not following these patients. So these type of long-term effects of these drugs are still to be explored because these are very toxic drugs as compared to the normal antibiotics or normal drugs we consume.
Very
So
valid point.
these
Yes.
can have a very long-lasting effect. I have not come across those good studies where we can really establish that we anesthesia are at fault in putting a long-term morbidity in these patients.
So food for thought and potential for research.
Yeah, that's why I asked only you because you are the teacher.
Yes.
Navneet is
Very valid
not
point.
suitable for Navneet.
Yes, yes.
Dr. Madhuri, you want to ask?
Navneet, I have two questions for you.
Yes,
One
ma'am.
would be, what would be your ventilatory strategy, intraoperative ventilatory strategy for this patient?
Strategy, I would uh, go with a tidal volume of around 300 to
You should
400.
mention per kg.
Per
Navneet.
kg.
Yes, ma'am. 300 to 400. 6 to 8 ml per kg, ma'am.
Yes.
With
The goal to maintain EtCO2
between 35 to 40. And
Would you add PEEP?
yes, ma'am. PEEP, depending on the status, so I'll decide on it. I'll initially start with a PEEP of 5 centimeters of water, and if required, I'll increase it
Maximum of
up to 8.
Around 8. Why
Yes,
why
ma'am.
are you scared of more PEEP?
Ma'am, the patient, there's already hypovolemia, so and the cardiac output, more PEEP will uh, more PEEP will actually decrease the circulating.
Renal
Yes,
problem,
ma'am.
right?
Yes,
Already
ma'am.
you're scared of hepatorenal syndrome and so many things, right?
Yes,
And you
ma'am.
were telling about, So you will adopt a lung protective ventilation strategy, right?
That's what
The
ma'am wanted you to say. So lung protective strategies, excessive PEEP is going to exacerbate the renal hypoperfusion.
Yes.
Okay.
And one more question, Navneet. What would be your IV fluid of choice?
This got left out. Good. You
Yeah.
I
What
would
would be
prefer
IV
a
fluid of choice? Huh?
I would prefer a balanced salt solution, ma'am.
What do you mean by a
Like
balanced salt solution?
the solution in which the composition is almost similar to that of plasma, and
So can you give examples of such solutions?
plasma light, ma'am. Plasma light,
Okay. Would you use
and
Ringer's lactate?
ma'am, I would prefer not to use it as lactate is metabolized in the liver,
Excellent. So would
and
you use Ringer's acetate then?
yes, it can use.
What about colloids?
And what about normal saline also?
We'll prefer to avoid colloids, ma'am, because
Okay.
there's
Why?
already there was a
Why? What is the problem with Heta starch? It can cause renal dysfunction, right?
dysfunction and also
Okay.
affect coagulopathy.
Yes.
Okay.
Yes.
What
Something
about
in your
gelofuscin?
pathophysiology only.
Yes,
Yeah.
ma'am.
What about gelofuscin? Coagulation problems,
Yes, ma'am.
right? But what about albumin?
Albumin again can be given, but there
Your
are
patient has ascites, no?
yes, ma'am.
Mm-hmm.
So it's only indicated when there is large volume
Yes,
is
but
removed.
the problem is the high cost and the availability.
Yes,
It will not
And
be
for
available.
this type of surgery in this patient, albumin may not be indicated, but
Definitely.
for hepatectomies, it may be indicated.
Yes. That is
The
for more
patient is-
major invasive
Yeah.
surgeries, right?
If the patient is undergoing hepatectomy, you can use intraoperative albumin.
And if there is some amount of systolic diastolic dysfunction, you don't want sudden hypervolemia also which can occur with albumin. Remember, okay? So
Yes.
it's normal saline, Tony?
no, ma'am, we'll not prefer. It will
Why?
also cause hypochloremic metabolic acidosis.
Acidosis in large
So
amounts.
it might, yes, ma'am.
Good. Excellent presentation.
Yes, excellent presentation. Very well done, Navneet.
Thank you very much.
Navneet, why you are so scared today? See,
I hope he's not scared from us.
No,
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 not from you. Not from you. He's generally, I think, it's a good platform. People like Navneet, when they are coming to the national, they
Absolutely.
are a source of inspiration to other PG students also of their equivalent years. So this is why, because if you can answer on this national platform so many questions, and these are not from the four people, two internal, two external. These are from so many externals.
Yes,
So they
absolutely.
are handling all the questions, and invariably they are scoring more than 90% in answering those questions also.
Yes,
That's
and
it.
Dr. Bajwa, both Navneet, I'm really thankful to Dr. Upma for all the support she's given us, and Navneet, who's prepared the case in just 2 or 3, he went rushing to the emergency to look for a case and was able to read up in just a couple of days. So that's really commendable. And thank you, Upma, for all the help.
Thank you, ma'am. For
Yeah.
the guidance. Thank you, ma'am. Thank you, Dr. Bajwa, sir, and thank you, Madhuri, ma'am, for wonderful discussion. And thank you, Shrabani. I hope I'm pronouncing your name correctly.
Correctly.
Thank you, ma'am, for this wonderful opportunity. I'm
So,
really grateful.
my
Thank
screen
you,
is visible?
Yes, thank you so much. Yes, it's very much visible.
Yeah. So see, the name is there, the director, Professor Dr. Anju Singh.
Yes.
Okay. Thank you so much for this holding this class. Madam Upma,
Thank
similar
you, sir.
sentiments for you also. I
Thank
know
you.
the hard work goes in preparing the PG students, and you have done a wonderful work along with Dr. Anju Singh, and it's a commendable job.
Thank you, sir. Thank you.
नवनीत तुम्हें पासिंग सर्टिफिकेट दे रहे हैं देखो ठीक है आईएएस से
Thank you,
नेशनल
sir.
से पासिंग सर्टिफिकेट मिल गया तो यू हैव पास द एग्जामिनेशन
It will be a bonus if he gets a long case of liver in his examination.
and it
Very
is a
much
It
hope
will be a
so, ma'am.
bonus for it.
lottery for him.
Yeah.
Shrobani Sarkar.
Thank you,
She
sir.
she's so enthusiastic, na? She I think agreed on the one go. So Shrobani, thank you very much, and you
Thank
have done a wonderful job with the confidence.
Thank you, sir.
And Dr. Padmaja, you also did a wonderful job. The only thing was the connectivity problem. No problem.
Yeah,
Next
yeah,
time,
it started raining here, sir. That is the main problem, actually.
it's okay. I know that the connectivity sometimes remain an issue. That's the only thing. Otherwise, I know you did a wonderful job also.
Thank you, sir.
Thank you,
So
sir.
I'm thankful to Dr. Madhuri and Dr. Nishant also, who is not there, but they were preparing all the team very well. Our coordinators, screen coordinators, and the PG students. It's a wonderful effort. And I think this class now will be available on the YouTube after this class is over from here. People can watch, all the students can watch for their examination. It will be very helpful. And they will see Navneet speaking. He is a national PG now, isn't it? So,
Celebrity.
Thank you, sir.
yeah. Anybody else wants to suggest or give the points or say about this thing? They can raise hand, they can unmute themselves, and they can tell here. Anybody, we can give 50 minutes. I think you people have explained it beautifully. Every point has been taken care of, and the rest were taken in the questions also. So it's a wholesome class. The liver cirrhosis is cured. The patient will go in a very fine manner. Cirrhosis corrected, rectified, and the patient will have a good. And you must, I think, as I told Dr. Ranju, the research has to be there. These type of thesis
Yes.
should be given to our students also. The
Yes.
follow-up studies, because as you know, in the globe, nobody follows the patient for a long time after the anesthesia effect, especially the hepatic cases. If we
Yes.
follow this norm, I think we may come out with a very good data in the future, leading the Western world regarding such type of research and
Some
thesis.
outcome measures need to be defined for the follow-up and
Yeah. We can always have a parameters to be particular, start with particular parameters, what effects is going to have on the long-term effects on the hepatic tissue. Not hepatic tissue, rather the whole body. Different systems, they are interconnected, like hepatorenal syndrome we are describing here. The other systems are also connected to liver. These are the things which will always make our science advanced. And anesthesiology has a huge scope. I think we
Yes.
are just exploring it only on the perioperative arena. Since we come out of the perioperative arena, we have make mark in the ICUs and pain clinics. Now this is a long-term follow-up with we can have a follow-up clinics, anesthesia follow-up clinics in the future, where we can really have a good research. Integrated research has already come out in the NMC as one of the department. So we
Right.
can be part of those research projects also. Wonderful class.
Thank
And
you.
I thank you everyone, Dr. Ranju, Dr. Rupma, Dr. Navneet, Dr. Sravani, Dr. Padamja, and more importantly, Dr. Madhuri and Dr. Nishant for today's wonderful work. Now it's a time to say goodbye. So we will end up saying, long live ISA.
Long live
Long
Only
ISA.
live
by
ISA.
Right, everyone.
Jai
Thank you,
Hind.
sir.
Good
Thank
night.
you, ma'am.
thank you,
Thank you
sir.
so much. Thank you, Dr.
Thank
Madhuri, and
you.
thank you, Dr.
Thank you,
Bajwa.
ma'am.
Good
Thank
night.
you.